In later line setting in gastric cancer, when patients have received the first line and the second line treatment, we do offer patients who still have good performance status, either cytotoxic drugs known to be efficacious and known to be non-cross-resistant to the previous compounds, such as docetaxel, paclitaxel, or irinotecan. It depends on the components of the regimens that have been administered in the first and second line setting. And later on in the course of disease, also we do use immunotherapy, which means checkpoint inhibitors. It depends on the country. So in Germany, we limit the use of these drugs to patients having either MSI or a PD-L1 overexpression. But sometimes also we use them in patients with high mutational burden. These are the most frequent drugs used in the later stage setting.
FTD TPI, TAS1-2 is one of standard of care as a third line or later line in advanced gastric cancer. The reason why is the TAGS trials shows a strongly benefit of overall survival in such lines of gastric cancer. The data is very similar to ATTRACTION-02 using nivolumab. TAGS trials shows a hazard ratio of overall survival is 0.69 and median overall survival time of FTD TPI is 5.7 months, quite similar to nivolumab arm in Asian population in ATTRACTION-02. And TAGS and TAS1-2, ATTRACTION-02 nivolumab is both agents and pembrolizumab in United States. 3 agent is one of the standard of care as a third line or later line treatment for advanced gastric cancer. But TAS1-2 is disease control rate also very similar to nivolumab or pembrolizumab, around 40%. However, response rate is just only 4% in TAGS trial in FTD TPI, a little bit lower response rate compared to ICI, immune checkpoint inhibitors. And then if we hope the patient need to tumor shrinkage, we often use ICI therapy as a third line or later line setting.
We now have defined third and fourth lines of therapy in gastric cancer, again, based on randomized clinical trials. So as we discussed earlier, typically in the West, a patient would get upfront FOLFOX. Second line treatment would be paclitaxel plus ramucirumab. Third line, we could consider the use of irinotecan-based treatment. And now we have trial data, randomized trial data to support active treatment options in the refractory disease setting. In the West, the most recent positive trial in the refractory disease setting was the TAGS trial, which was the randomized trial of TAS102. This is a combination of tipiracil and fluorinated pyrimidine and an oral preparation. So TAS102 versus a placebo plus best supportive care and chemotherapy refractory gastric cancer. The TAGS trial did show a modest 2-month progression-free survival benefit for TAS102 versus supportive care alone, and also a modest 2-month survival improvement over best supportive care. So based on this study, TAS102 is now a treatment option for patients with chemotherapy refractory gastric cancer. So now we have an approved third or fourth line option for patients with advanced gastric cancer. The other option is in patients who are PD-L1 positive. Based on the KEYNOTE-59 trial, which was an expansion cohort, a large phase 2 cohort, looking at pembrolizumab and esophagogastric adenocarcinoma, nearly 250 patients. About a little bit more than 50% of patients did test PD-L1 positive. And what this large expansion cohort showed was a meaningful response benefit for pembrolizumab in PD-L1 positive patients. The response rate was about approaching 15%. If we took out the MSI high patients, it was about a 10 to 12% response rate and a tail on the survival curve. For the PD-L1 negative patients, the response rate was 5% or less. So based on this signal of activity, pembrolizumab was approved in the United States for patients with chemotherapy refractory esophagogastric adenocarcinoma whose tumor tests PD-L1 positive. So that also is an option. How I would line up these treatments would be in a patient that's progressing first and second line treatment. If they're PD-L1 positive, third line, I would probably use pembrolizumab as the approved option. If they're PD-L1 negative, I would probably consider use of TAS-102 as the first salvage option. And the MSI high patients also factor here as well. We talked that we might consider, talked about earlier, that we might consider earlier use of immune checkpoint inhibitors in MSI high patients. Certainly in an MSI high patient that's progressing on first and second line treatment, checkpoint inhibitor therapy would be the first choice because we see, again, quite high responses, 40, 50, 60% of patients responding, many not even achieving a median survival. The response and survival benefits are ongoing for these patients. So in MSI high patients, checkpoint inhibitors would be high on the list in terms of salvage options as well.